a big applause to the previous speakers. David, it's your turn now. So we'll start block number 4 with Professor David Systrom from Dyspnea Center and Advanced Cardiopulmonary Exercise Test Program, Brigham and Women Hospitals, Harvard Medical School, Boston, Massachusetts, USA. And Professor David will talk about neurovascular dysregulation, preload failure, mitochondrial dysfunction. And he used his own mic, of course.
All right, success. Thank you for the kind introduction here. And it's a pleasure to follow Dr. Keller's talk with a different version related, I think, to her version of cardiopulmonary exercise testing. My topic is broad. Some of you may have noticed that we've changed the order here. Drs. Waxman and Oliveira are going to discuss their findings using invasive cardiopulmonary exercise testing later on this afternoon. So I'm going to set the stage perhaps for some of that. Here's what I'd like to tell you about over about 30 minutes or so. I'd like to introduce those of you who don't know much about the invasive version of the cardiopulmonary exercise test to it and what we can derive with a couple of catheters. And then I'm going to pit two different avenues of pathophysiology during exercise against each other to a degree, and that's the notion that some of what our patients notice in terms of fatigue and shortness of breath and lightheadedness might be related to decreased oxygen delivery to the exercising skeletal muscle. Then I'm going to turn to a different notion. So a little bit on the invasive cardiopulmonary exercise test. First, Betsy has told you all about this. This is Dr. Carl Wasserman's favorite gear diagram that graces his textbook and the business. Shown here is the interface with the environment where we have minute ventilation. We collect that, of course, with a pneumotachograph and a mouthpiece. The amount of oxygen uptake from the environment, the amount of CO2 exhaled. And then if everything's working perfectly, all these gears work in sync. And you have, for instance, oxygen flowing with a convective step, a diffusive step into the red blood cell, another convective step with cardiac output, delivering that oxygen. And at peak exercise, about 80% of the cardiac output is being directed normally to the exercising legs in our case with cycle ergometry. And then finally, there's a diffusive step out at the level of the mitochondria, and it falls normal with the mitochondrial machinery and the delivery of the oxygen. It's taken up properly, and off we go, and we feel well. If there's any portion of these gears that is in disarray or out of sync, presumably symptoms ensue, things like fatigue, shortness of breath, lightheadedness. And then the reverse occurs with CO2 and hydrogen ion excretion. So that's the non-invasive portion that can be measured non-invasively. It's scalable. Many folks are doing this. So the invasive variety is shown here, and I'll point out a couple of highlights. This gentleman agreed to be filmed. Here's the pneumotachograph I mentioned. This is the connection to the metabolic cart, so breath-by-breath pulmonary gas exchange. And then there are two special catheters that really help us inform the interior, what's going on in the interior of the exercising human being. They're put in our cardiac cath lab around the corner from the exercise lab by Dr. Waxman, whom you're going to hear from in a little bit. This is the pulmonary artery catheter placed in the right internal jugular vein. And then in this gentleman's left wrist is a radial artery catheter. And as Johanna Squires told you yesterday, we get pressure measurements, we get biomarkers, we get arterial blood gases, mixed venous blood gases, and a phenomenal amount of physiologic information. So again, here are some of the measurements that we make. These three up here are non-invasive. This is minute ventilation, VO2, all the way up to peak, CO2 output. And then from the arterial catheter, you'll see, importantly, arterial oxygen content. from the tip of the pulmonary artery catheter, mixed venous oxygen content, and you'll see that that is very important in assessing whether there is dysautonomia and abnormalities of oxygen delivery or its subsequent uptake and utilization. And then we have a variety of pressure measurements. Joanna alluded to some of these yesterday. We've got the mean pulmonary artery pressure, that's the input pressure into the lungs, and then we've got a surrogate for the left atrial pressure, pulmonary capillary wedge pressure shown here. So pressures in and out of the lungs, and then pressures feeding the right heart. And this is going to be a super important entity, as you'll see, in both ME and long COVID. These are the filling pressures in the upright position that reflect normal autonomic function, sympathetic squeeze on the big veins, the capacitance veins, and whether or not they squeeze properly and physically push blood up to the right heart. You're going to be hearing more about that from me and later today. And here's the Fick principle Rob Voos mentioned. This says that the O2 uptake is related to the cardiac output and the difference between the arterial and mixed venous oxygen content. So this is true at any point in time. I'm going to emphasize today maximum exercise. And what you can view, and I think Betsy said this a little bit ago, the VO2 tells us how much metabolism the patient is doing out in the real world. And with an incremental test, we can say, okay, at 600 ml, you're walking down the hallway, and at 800 or 900, maybe you're running up the stairs. And then there's maximum exercise when presumably all of our physiologic compensation is maxed out. But it is related to cardiac output and then the difference between these two things. This normally goes up about 5-fold above resting values if you're normal, and this normally falls about 3-fold, and this stays the same. If we rearrange the Fick principle, we get cardiac output, and we measure that at the Brigham with the invasive test every minute during exercise. This is continuous, and this is measured simultaneously with this every minute. I want to remind you, though, that this cardiac output that we are measuring is pulmonary blood flow. If there's no shunting going on of blood, that's going to be equal to systemic blood flow. But what we have found in first ME and then more recently long COVID is a different story that I'll talk to you about. Here's an algorithm for what we deduce from the invasive exercise testing program. I'll run through it briefly. We're going to emphasize really 2 buckets here in the end. So here's the VO2 peak that Dr. Keller alluded to, and here's a crude cutoff for normal. Many of our patients with ME and long COVID actually are better than this, and we can find abnormalities if we dig deeply, and I'll go over those. This is a so-called pulmonary mechanical limit. This is really not germane to the type of patient I'm going to be talking to you about today. This is a patient with parenchymal lung disease, perhaps in long COVID, an occasional patient with interstitial lung disease following ARDS. I will not be talking about that type of patient today. This is a central cardiac limit where the VO2 peak is decreased, and there's a similar or symmetric reduction of cardiac output, which we can express as a percent predicted. And if we find that, we can determine whether the left heart dysfunction is at play, the right heart and pulmonary hypertension, or something we call preload failure. And this is where we're going to end up with a majority of patients with ME and long COVID. An occasional patient with long COVID may have a cardiomyopathy. An occasional patient with long COVID may have persistent pulmonary embolism that we diagnose with this, but I won't be talking about those rare cases. The vast majority of patients with long COVID and ME end up here. That's low. Here, to a degree, that's low, and preload failure. Now, at the other end of the universe is the arterial side, and this is reflected largely by the ability to extract, take up, and use oxygen that's been delivered to the exercising muscle. And as I said, this mixed venous oxygen content should normally fall about 3-fold, but we have found in a subset of individuals an abnormality here, whose differential, and this is a spoiler alert, includes these 2 entities: intrinsic mitochondrial dysfunction that you heard about from Dr. Voos, and a peripheral left to right shunt or associated abnormalities that I will come back to. So these are on the arterial side. This is on the venous side. I'm going to begin with the venous side. just pay a little attention to this. So we first got into this business about a decade ago when we discovered something we call preload insufficiency. And it is a form of decreased oxygen delivery. Oxygen delivery is defined by that cardiac output times the oxygen content in arterial blood, that product. That's what's going out the aorta during exercise. We don't know what happens to it with this type of testing after it goes out the aorta, but there's a subset of individuals who have predominantly preload insufficiency and normal oxygen extraction. We call that a low flow group. And this we began to put on the map with the help of Philip Joseph, now at Yale 4 years ago, published here. So this is what it looks like. This is a low flow group of ME patients, but we have found the same thing in long COVID, where the predominant abnormality by the Fick principle is a depressed peak exercise cardiac output that decreases the VO2 peak and presumably causes symptoms. So they have a low cardiac output. We are expressing it here against the VO2, a slope, and their extraction of oxygen, shown here corrected for the hemoglobin, is normal. This is the low flow group. It's kind of pure preload failure. It tends to be more common in males, and this is where they end up here in our bucket. The next entity I want to talk about and spend most of my time on, though, is what got our attention with that same Philip Joseph paper, and it's a bit of a different entity. So it's impaired systemic oxygen extraction, defined by the inability to depress the normal mixed venous oxygen content, shown here. This is where they ended up in that particular paper. They have high flow compared to normal, shown over here in gray, and the intermediate group, and certainly the low flow group. This is a lot of pulmonary blood flow and poor systemic oxygen extraction. And by the Fick principle, the reason for their decreased VO2 is predominantly a depression of its inability to depress the mixed venous oxygen content, impaired oxygen extraction with a lot of pulmonary blood flow. Here's a more recent look at our data, and Johanna Squires presented some of this yesterday. She did all of this heavy lifting. This is our most recent experience with the invasive CPET in ME/CFS over the past 5 years. We have 450 patients. We have now actually 93, but I'm showing you 89 long COVID patients and a cadre of normals. And as Johanna told you yesterday, we've got symmetric decreases of the VO2 peak. Preload failure is the right atrial pressure over here. We've got cardiac outputs that on average are down when compared to normals. And we've got depressed oxygen extraction on average down compared to normals, and no differences between long COVID and ME/CFS. Now, I want to focus on these two groups. So this is kind of the newer thinking about at least a subset of patients with both ME and long COVID. And that's that high flow shown here. So this subset of patients with cardiac outputs that are way north of 100%, 120, 140%. VO2 peaks that are up a little bit, but depressed compared to the cardiac output, and then whose abnormality of the Fick principle is abnormal O2 extraction here. This is really the high flow group, predominantly women, and we're looking for reasons for that. So all the things I just told you about, a lot of pulmonary blood flow and poor oxygen extraction, are hallmarks of something the cardiologists call left to right shunting. And we've known forever in congenital heart disease, more common in adults, is an atrial septal defect where you push oxygenated blood across the atrial septum onto the venous side, and the pulmonary circuit is on overdrive, lots of blood flow through it, but it's ineffectual. It's not getting out to the periphery during exercise. We know none of our patients has an intracardiac defect in left to right shunting because Dr. Waxman does a very special step-up measurement of oxygen from the superior vena cava through the right atrium into the right ventricle and out the pulmonary artery. There's no step up there. So we think this is peripheral left to right shunting. And we have an example of this from one of our collaborators, former professor to Dr. Waxman, skin biopsy of the hypothenar pad which captures the epidermis shown here and the dermis with the blood vessel supply. And what Frank Rice in Albany showed us with these elegant studies is very interesting. We've got an artery coming into the skin, and this can happen in other organ systems, but the skin is accessible by biopsy. We've got a vein draining the skin, and we've got a potential shunt between the two, the artery and the vein. And that shunt is enveloped with something called small fiber nerves. Those small fiber nerves, amongst other things, secrete vasodilators. They can be dynamic and open up. And I ask patients in the clinic, when you get in the hot shower, do you get dizzy and your feet turn purple? And the answer is a phenomenal prevalence of yes. So we think some of this may be going on in exercise, but it doesn't have to all happen in the skin, which is capable of receiving at least half of the cardiac output. But some of it may be in the skin. But it's peripheral left to right shunting. Now, this link to small fiber neuropathy is prompted by some of that Frank Rice data, and I want to tell you about that. This is a form of dysautonomia diagnosed by a skin biopsy. So the small fiber neurites have been known forever to mediate nociception, pain, and that's fibromyalgia in our business. So it's defined by a lack of dendrites, of neurites in the epidermis classically. But we now know that these same small fiber neurites not only mediate pain, but they provide an autonomic function as well. They envelop blood vessels, as I just showed you, in the skin, and they are responsible for blood vessel tone and therefore blood flow. When they're missing in action, of course, they're not able to do their thing, but the ones that remain are often overactive and dysfunctional. So here's our most recent look, again, with the help of Johanna Squires, who presented this in Amsterdam just a month ago. We have a phenomenally high prevalence in both long COVID and ME of either definite or probable small fiber neuropathy, approaching 2/3 to 3/4. So a very high association with this autonomic nerve problem that goes with some of the vascular abnormalities I've just described during exercise. So we're inclined to link the two, although the exact link is not well known. So this is where those patients with high flow end up. They have a depressed VO2 peak and symptoms. Most of them additionally have some element of preload insufficiency, but here's the extraction of oxygen problem, which I would like to focus on a little bit more here for a minute. Now, a nod to some of our prior speakers this morning, and some of this has been alluded to. I would ask the question, if I'm proposing to you a hypothesis that dysautonomia is responsible for some of the systemic oxygen extraction problem, am I sure that that's the only mechanism? And the answer is a definitive no. So there are lots of other potential reasons, none of them mutually exclusive, to impair oxygen extraction during exercise. One is abnormalities of the hemoglobin itself, or red blood cell abnormalities. You heard Dr. Pretorius talk to you about. The microclots, of course, that she told you about can physically gum up the microcirculation and create a mismatch between perfusion of the mitochondrion and the muscle and metabolism. Endotheliitis and structural changes of the capillary and the muscle can give you these very same changes. And then finally, there's the notion of intrinsic mitochondrial dysfunction, which I'd like to supplement Rob Booth's work on with the following. So here's this entity. We have preload failure on the venous side. We have potential dysautonomia on the arterial side, but additionally an intrinsic mitochondrial defect is possible. So I want to address mitochondrial dysfunction in two different ways. One is number, or better biomass of mitochondria, and we can measure that with something called citrate synthase activity with a fresh muscle biopsy. It's a ubiquitous enzyme at the entry into the Krebs cycle, and it reflects the number of mitochondria and the biomass of the mitochondrion. Additionally, one can look for biomass of mitochondria by looking at mitochondrial DNA copies, and these two correlate. We've done that correlation. I won't show it to you today, but they correlate very nicely. And then finally, with biomass, there's a notion of fission and fusion. Healthy mitochondria get together, and the defective ones are supposed to be tossed out at the edge of the herd. So that's biomass. That's the number of mitochondria effectively that we find in the muscle in this case. But then there's function as well. So the classic way of looking at function, you heard from Rob Woost, is oxidative phosphorylation and looking at the individual electron transport chain intermediates. So I'm going to tell you a little bit about that. We utilize, as I think Rob does for the most part, a frozen muscle biopsy to interrogate function. And we get complexes 1 through 4. 5 is missing in action. With a frozen, you can get it with a fresh biopsy, which is harder to do and analyze. And then finally, EM morphology, which the Woost group is looking at. So here's what's known about genetic forms of mitochondrial myopathy. This is not ME CFS. This is UT Southwestern 20 years ago with genetic forms where they quantify the mutation load in the skeletal muscle itself as a percent here. So worse mitochondrial genetic myopathy shown left to right here. And what they found with a similar approach to our invasive CPET is impaired oxygen extraction as a function of mutation load. So read mitochondrial dysfunction in the limb skeletal muscle results in impaired oxygen extraction. Now, what about biomass? What about the number? So with the help of Bob Navio, who's a mitochondrial maven at UCSD, we have looked at his group of well-defined OXPHOS disease. These are some pediatrics, some adults, but a large number of them he's published in the past at the biomass, measured by citrate synthase compared to normal at Baylor. And you can see that it's actually increased. And one can envision a system where you have a primary defect in electron transport chain and a compensatory increase in the number of mitochondria. So that's genetic forms. But what about ME and long COVID? So we find something different. Our mitochondrial biomass by citrate synthase is decreased. We have fewer mitochondria in the muscle of ME and long COVID. So this is a hypothesis that there is failure to generate the biogenesis of mitochondria is defective in some fashion in ME, and it's different from the genetic forms. All right, what about ETC function, and how does any of this relate to the oxygen extraction problem that I've just described to you from the invasive CPET? So first, our mitochondrial biomass by citrate synthase activity here, and the answer is the worse the systemic oxygen extraction, the greater the number of mitochondria. The fewer mitochondria over here actually have better extraction. So maybe one could envision a reciprocal relationship between mitochondrial number and the extraction. So what does give us poor oxygen extraction? I gave you some of the vascular abnormalities that are at play here, but is it possible that intrinsic mitochondrial dysfunction, presumably acquired, not genetic, in ME and long COVID is related to it? And our preliminary answer, unpublished, but we've submitted this for ATS in Orlando next May, is as follows, that the poor oxygen extraction during an invasive CPET is at least associated with the impaired ETC chain function. So that part is similar to genetic disease. So here's our cartoon of a hypothesis. The genetic forms of mitochondrial myopathy, we think the primary defect is a defect of energy metabolism. The function is down, and in a compensatory fashion, they have regulatory pathways that upregulate the biomass of the mitochondrion. Conversely, in ME and long COVID, we have a primary defect of mitochondria. There are a few of them, and function can go either way. If you have poor oxygen extraction, that's explained by poor function in addition to the decreased biomass, and one could envision a double hit in those patients. They have both fewer mitochondria in the skeletal muscle and their function is decreased, presumably resulting in more symptoms. So I'm going to end with that and thank our team who's in the back here and shown in this picture, and many others, Dr. Waxman, whom you're going to hear from, and too many others to count here. And thank you for your attention.